GI bleed. 50% of bleeds are from the upper GI, 40% lower GI, 10% is occult. You say a bleed is severe if there's a drop in blood pressure, there's orthostatic hypotension, hematocrit decreases by 6%, hemoglobin drops by 2 gram percent, or if there is a transfusion with minimum 2 units PRBC needed. Hematemesis is when there is fresh GI bleed from the nasopharynx, esophagus, stomach, and duodenum. Melena is when there is black tarry stools due to the degradation of blood or hematin by intestinal bacteria of the blood that's gone into it. The bleed is from the upper GI, small bowel, or the proximal colon. And it happens when the blood is more than 50 to 100 ml. Occult bleeding is subacute bleed, but it's not clinically visible because occult means hidden. Obscure GI bleed. The bleed is from a site not apparent after an evaluation with an OGD push enteroscopy and colonoscopy. You check the vitals, the heart rate, postural drop in blood pressure, abdomen for scars, masses, tenderness, the skin for spider angiomas, palmar erythema, Dupuytren's, which would give away that there is probably an underlying variceal bleed for cirrhosis, subungual telangiectasias for scleroderma, lip skin telangiectasias for HHT, Osler-Weber-Rindu syndrome, pigmented lip lesions for Peutz-Jeghers, palpable purpura for HSP, and acanthosis for gastric carcinoma. Management of a severe GI bleed. We do the blood works, we stabilize the patient, we insert a 14 or 16 gauge needle, we give IV fluids, and we maintain the blood pressure more than 100 and a heart rate of less than 100. We give terlipressin or octreotide or somatostatin if we suspect CLD and a variceal bleed, PPI infusion if we suspect an ulcer. We do an OGD in 6 to 12 hours after stabilization, and if the patient is stable, we can defer a colonoscopy to up to 24 hours. You transfuse to keep the hemoglobin more than 7 grams and the platelets more than 50,000. You use a 34 French orogastric tube in severe bleed for lavage to remove clots and for visualization during an OGD. IV metoclopramide or erythromycin 30 to 90 minutes before an OGD will induce a gastric contraction and propel the blood from the stomach. In severe lower GI bleeds, you can purge with a PEG preparation 6 to 8 liters via the NG tube in 4 to 6 hours until the rectal effluent is clear. And then you give metoclopramide 10 milligrams before the purge and repeat every 6 hours. And you do the colonoscopy in 12 to 24 hours. If there's mild to moderate lower GI bleed, you can do a colonoscopy in up to 24 hours. The source of bleed is not found, you do an abdominal CT angiogram and you can do an embolization of the bleeder. If the source is not found still, you can do a video capsule endoscopy. And if you're unable to control the bleed, you can do an emergency laparotomy. Why do we do a CT scan before a video capsule endoscopy? To rule out an obstruction or the capsule won't emerge, creating an emergency. Complications of emergency endoscopy are perforation, bleeding, aspiration pneumonia in upper GI endoscopy, hypotension, and hypoxia. Endoscopic hemostasis, we can achieve it by thermal contact probe. You physically tamponade a bleeding vessel and then heat it applied for 8 to 10 seconds. But the main risk is a perforation, and you can make the lesion larger and deeper and cause a delayed bleed. Injection therapy can be done with adrenaline, which is 1 in 10,000 or 1 in 20,000. It's low cost, lower risk of perforation, but it's not so effective. You can use a sclerosant like alcohol or ethanolamine, but there's an increased risk of tissue damage. You can do an endoscopic hemoclip. You can do a band ligation, suction the mucosa and submucosa over the vessels into the cap at the end of the endoscope and roll the band over it. Imaging. Angiography is sensitive. The sensitivity is 30 to 50%, specificity is 100%, but you can pick it up only when there's an active bleed. That's more than 0.5 ml per minute. You can give therapeutic interventions like intraarterial vasopressin, or you can do an embolization. Technetium labeled RBC scintigraphy is mainly useful in Meckel's diverticulitis. If the age is less than 25 years, it has a positive and negative predictive value of 90% for Meckel's. And you can do it only if the bleed is more than 0.04 ml per minute. It gives a 25% false positive and it's less used. Rockall scoring for upper GI bleed. 0 score for age less than 60, pulse less than 100, systolic BP normal, no comorbidities, and Mallory-Weiss tear, and no stigmata of recent hemorrhage. The score of 1 for all these factors, age 60 to 79, pulse of more than or equal to 100, systolic BP of more than or equal to 100. Comorbidities are nil, differential diagnosis of a benign lesion, and stigmata of recent hemorrhage are absent. Forest classification. So 1A is active spurting, and 90% of the time, if you don't do anything about it, it will rebleed. And if you do something about it, like a hemoclip, that's still the risk of rebleed is 15 to 30%. That's a 1A. 2A is also a bad one. That's a non-bleeding visible vessel. There's a 50% of chance of bleed if you don't do anything about it, and 15 to 30% if you do. 1B is just simply oozing. The risk of rebleed if you don't do anything is 10 to 14% and 0 to 5% if you do a hemoclip. 2B is an adherent clot. 33% chance of a rebleed if you don't do anything about it, 0 to 5% if you do. 2C is a flat spot, 10 to 15% chance if you don't do anything, 0% if you do. 3 is also with a clean base, you don't do anything about it because there's only a 3% chance for rebleed. On the left, we have an active spurt, that's a 1A. Then you have an ooze, which is a 1B. Non-bleeding visible vessel is next to it. And then you have an adherent clot, a flat base, and a clean base ulcer. Techniques for endoscopic hemostasis. Forest 1A and 2A, we inject 0.5 to 1 ml of 1 in 20,000 adrenaline into 4 quadrants within 2 centimeters of the bleed. Then you use a coagulation with a 10 French multipolar probe or a hemoclip. You use a DEP guidance to trace the direction of the artery, and you give them IV PPI for 72 hours. For an adherent clot, you inject the same dose of adrenaline around the pedicle of the clot, and then you use a rotatable cold snare to guillotine the clot piecemeal until you see the underlying lesion, and then you give the IV PPI for 72 hours. If there's oozing, that's a 1B. Adrenaline injection is usually enough because the rebleed risk is less than 5%. In a flat spot, that's a 2C, 40% DEPs show underlying arterial blood flow. Of these, 50% would rebleed if there's only medical management given. Therefore, we have to inject adrenaline and do a hemoclip. The ulcer with a clean base, that is Forest 3, you don't have to give them any treatment. Newer endoscopic therapies. Hemospray is used in an adjunct. It can stop the bleed in both variceal and non-variceal bleed, but it does not treat the underlying cause. Over-the-scope clip is better than standard hemostasis to decrease a rebleed, but there's no randomized control trial yet. And then, if there is a rebleed, you can do an angiography and embolization, surgery, or over-the-scope clip. Always look for H. pylori and treat it. Repeat the OGD only after a gastric ulcer bleed, after 6 to 10 weeks of a PPI. If the bleed is from severe esophagitis, repeat the OGD after 8 to 10 weeks to rule out a Barrett's, and you biopsy them for CMV, HSV, and Candida. Bleeding in a hospitalized patient is usually either due to SRMI, which is stress-related mucosal injury. The risk factors are coagulopathy, mechanical ventilation more than 48 hours, or even due to a large focal chronic ulcer. A deulofoil lesion is a large submucosal artery which protrudes through the mucosa. It's not associated with a peptic ulcer. The surrounding mucosa is normal. and usually within 6 centimeters of the gastroesophageal junction. The Doppler endoscopic probe helps to identify this. The treatment options are band ligation, thermal probe, injection sclerotherapy, over the scope clip, and CT angiography and embolization. Mallory-Weiss tear, mucosal or submucosal laceration of the JE junction. It extends distally into the hiatus hernia. It occurs after a bout of vomit. It's usually mild but can be severe. The treatment would be, if it's active and there are no varices, you can just do a hemoclip. And if that fails, you can do an over-the-scope clip. But if there is an underlying varus, you treat the varices. A Cameron lesion is a linear erosion in the proximal stomach at the end of a large hiatus hernia. This is a cause for an obscure bleed. GAVE, or gastric antral vascular ectasia, also called watermelon stomach. There are stripes of ectatic vessels in the antrum, and it spares the body and the fundus, unlike in portal hypertensive gastropathy. It's a common cause of obscure bleed. It's associated with CLD, scleroderma, CKD, and in older women. The treatment would be band ligation superior to APC. Second option would be APC. Third option, radiofrequency ablation. And fourth option, if it's severe and ongoing, causing a chronic bleed, you can do a surgical antrectomy. Portal hypertensive gastropathy, severe hyperemia in the mucosa, ectatic blood vessels in the proximal body and the cardia. And there's oozing and there's blood loss. If it's less severe, it looks like a snake skin or a mosaic pattern. Severe portal hypertensive gastropathy, non-selective beta blockers can be used, TIPS can be used, surgical portocaval shunt can be used. Endoscopic treatment has no role except in focal bleeding lesion. Hemophilia. There's blood in the biliary tree. This can happen post-ERCP, trauma, post-liver biopsy, HCC, and because of parasites. GI bleed plus elevated liver enzymes gives it away. Diagnosis is by side-viewing duodenoscopy. You see the bleeding in the ampulla. The treatment is arterial embolization. Hemosuccus pancreaticus. It's a rare form of upper GI bleed. It's in children with acute or chronic pancreatitis. Post-ERCP procedures is prone for it. Pancreatic cancer is also a reason. The diagnosis by side-viewing duodenoscopy and the treatment is arterial embolization. Aortoenteric fistula. It causes an acute massive bleed with a high mortality. There's a connection between the aorta and the third part of the duodenum. These are secondary and primary. The primary is from an abdominal aortic aneurysm. It's connected to the third part of the duodenum. The secondary is after an abdominal aortic graft surgery, and there's a connection between the small intestine and the graft. The diagnosis by contrast CT scan. The only treatment is the removal of the infected graft or surgery. Bleeding gastric varices are hard to treat. You diagnose them by CT angiography, MRI, and Doppler. Treatment is focal gastric varices. You can put a cyanoacrylate glue, or you can do BRTO, which is balloon occluded retrograde transvenous obliteration. And if there's a splenic vein thrombosis, we can do a splenectomy. Esophageal variceal bleed. We give them terlipressin, 2 milligrams IV every 4 hours initially, and then we make it 1 milligram every 4 hours until the bleeding is controlled. Or if the patient has a coronary artery disease underlying or any peripheral vascular disease, we can't give them vasopressin. We can give them octreotide, 50 micrograms IV bolus followed by 50 micrograms per hour infusion. Or we can give them somatostatin, 250 micrograms bolus and 250 micrograms per hour infusion. We have to continue this for 2 to 5 days. Antibiotic prophylaxis is a must for all. Ceftriaxone 1 gram IV daily, or norfloxacin 400 milligrams twice a day in a low resistance setting. The duration is for 7 days and prevents SBP, rebleed, and mortality. Endoscopy. Early endoscopy within 12 hours is the procedure of choice. Early endoscopy is done within 12 hours. The procedure of choice is endoscopic variceal ligation. It's a first-line therapy. It controls the bleeding in 90% cases. There's a less risk for stricture, perforation, and mediastinitis compared to sclerotherapy. Previously, they used to do sclerotherapy with ethanolamine oleate. For fundic and gastric varices, cyanoacrylate glue is the treatment of choice. Newer modalities, over the scope clip. For duodenal ulcer, if the sclerotherapy plus thermal probe don't work, you can do an over the scope clipping. But sometimes this becomes the first choice of treatment when there's a large vessel underneath, when there's a fibrotic ulcer, or the patient's on antiplatelets or having CKD because of increased risk of bleeding with a thermal probe. If the bleeding persists, you do rescue therapy with a balloon tamponade. This is for an esophageal variceal bleed. That's a Sengstick and Blakemore tube. But this is a bridge therapy for less than 24 hours duration. Definitive rescue therapy would be a TIPS procedure. Early TIPS is within 72 hours. It's recommended in high-risk patients or in child's C less than 14 or in child's B with active bleed. Secondary prophylaxis after the bleed is controlled. We give them carvedilol, which is a non-selective beta blocker, or propranolol, and we can do a repeated endoscopic variceal ligation every 2 to 4 weeks until eradication. TIPS procedure. Expandable metal stent is placed via percutaneous insertion between the hepatic and portal veins, creating an intrahepatic portosystemic shunt. It's most effective for long-term prevention of a rebleed, but occlusion rate is 80% in 1 year, and there's a 20% risk of an encephalopathy. Lower GI bleed, the common causes are stercoral ulcer because of prolonged constipation in a bedridden patient, diverticulosis causing diverticulitis and bleed, CRC, colorectal carcinoma, ulcerative or infective colitis, polyps, and SRUS. Diagnosis of a diverticular hemorrhage. Definitive diagnosis is by the signs of a recent hemorrhage, stigmata of recent hemorrhage, which is active bleed, NBBV, that is non-bleeding visible vessel, and an adherent clot. Presumptive diagnosis is you see diverticulosis without SRH. Incidental is you see another lesion as a cause of bleed, and diverticulosis only incidentally detected.